So our objectives, which are on the next slide, are going to be to talk about common ways that COVID-19 is transmitted so that people in the community, the folks that you work with in the neighborhoods, can identify a lower or a higher risk situation for themselves and hopefully take the needed precautions, which would be neither too little nor too much to make sure they stay safe. We're going to talk about some effective strategies for preventing COVID-19. A lot of it has to do with vaccination, which I have to say has been, the development of vaccines very rapidly has been one of the great success stories scientifically and medically for the pandemic. And so it's been much more challenging, obviously, as you all know, on the social uptake side and the conversation about it in the public sphere, but we'll talk about that too. And we'll talk about skills for managing those difficult conversations, setting the tone, acknowledging different perspectives and areas of concern when you're talking with your patients or clients about the COVID-19 vaccine. Next slide, please. So just a tiny bit of biology to start us off so that it helps frame the way that we think about the virus. If your kids have ever been to elementary school or grade school, sometimes they come home with boils that they get from other kids. Those are bacterial infections, they're staph. So the bacteria that we talk about that cause infections often, they're actually alive. They can reproduce themselves, and their task is to do that very well, to spread to other people and so on. Viruses aren't alive in the same way as other creatures. They can't reproduce themselves. If you have a coronavirus that causes COVID sitting on a table top, until a human comes along and gets it inside of them, the virus would sit there forever and usually fall apart after a while due to heat or drying out. But it can't do anything to reproduce themselves in the same way as other bacterial infections. So what they do is they hijack our bodies to make and spread copies of the virus. So let's say you're talking to someone with COVID for a long time in a small space, maybe a foot or two away at a dinner table, and eventually you get infected. The virus gets into you usually through your breathing passages. So as you're talking to them, you're inhaling what they're exhaling, and the virus is part of that. The tiny mist that we don't see when we exhale. And then the virus essentially hijacks our cells to make copies of itself. And so just with that very simple understanding in place, we prevent spreading COVID in two ways. We don't expose ourselves to the virus, and the way we do that is by masking and social distancing. And then we make sure that our bodies are as hard for the virus to hijack as possible. And we do that through vaccination. And we'll talk more about that as we go through. So the next slide is just a simple cartoon version of a virus. This is obviously magnified many hundreds of thousands of times. And the virus is a particle that has the genetic material, the thing that helps it reproduce itself on the inside. And the trick for the virus is to get inside our bodies and move that means of reproducing itself from inside the virus to our own cells. And that's where I said they hijack our cells to make copies of the virus. And so the virus has something called the spike protein, which you may have heard of in sort of news accounts of how the virus works. And the spike protein it punches a hole in our cells, which allows the virus RNA to get inside and then start a festival of making new viruses inside our own cells. Next slide, please. So that's again, a very basic idea of how the virus creates copies and to create all the damage inside human bodies. Now, how does it get inside us in the first place? And at the beginning of the pandemic, there's a lot of unknowns about this. And it took us a while to understand really how it's transmitted. So one way that things get transmitted is by direct contact. You shake hands with someone, they have some mucus with coronavirus on their fingers, gets on your hand, later on, you're not thinking about it, you rub your eye, or you put your finger in your mouth or your nose, and that's the way it's transmitted. That's sort of a direct sort of chain of custody transmission from one person to the other. It turns out that the other way is actually much more common, and that's not through direct contact, it's through the air. So these virus particles are very tiny. They're light enough to float on the air. And what they're floating on is the air that we exhale as we cough or talk or share a space with someone. And so just knowing that one simple fact that it's mostly airborne, COVID-19, it points to the ways that we protect ourselves and that we can teach people to protect themselves. So one, and we all know this, is to be outside. Again, during the pandemic, we heard if you're going to eat out, try and sit someplace outside, not in a crowded restaurant, but out on the patio where the breeze is blowing. And as we exhale the virus gets carried away to who knows where, but not to the person sitting next to you on that breeze. So the wind is your friend. If you can feel the wind on your face, probably it's a much lower situation. If you're indoors and the weather permits it, open the windows. Again, that opens your home to fresh air, creates a little breeze inside the room that you're in, and helps protect you. And then the other thing is to socially distance. So the closer you are to someone who's coughing or sneezing or talking next to you, the less that air has a chance to spread out and reduce the concentration of virus that you're exposed to. So that 3 feet or 6 feet makes a big difference from being, 1 foot or 1.5 feet away from someone. And scientists have actually made some movies showing exactly how this happened. If you could look at the next slide. This is showing the air that we exhale during the conversation. And these are two unmasked people. And you can see that the air, as they talk to each other, is projected right into the other person's face. And it's very easy for it to be carried that way. And these people are, what it looks like maybe a foot apart, maybe not more than 1.5 feet. And so there's very little room for those exhaled vapors to spread out and carry less virus concentration. If we go to the next slide, we have movie pictures of people who are masked. And you can see that, and the little mist you can see in front of both of their eyeballs, and where their air that they're speaking with is going up and out the mask, but instead of being projected directly into their friend's face, it's going up and out of the way. And that's what masks do for us. In addition to trapping any particles of saliva, anything that happens when we create the letter P, for example, they're not going straight into the other's face, they're trapped by the mask. But then the air that we exhale obviously has to go somewhere. It doesn't all get trapped in the mask, otherwise the masks would have to be as big as a hot air balloon to do that. But it's directing it up and away from the other person instead of directly in their face. So this is a simple idea that you can help explain to people, well, why are the masks so important? This is exactly why. Next slide, please. So the million-dollar question is, we started with this in 2020. It's a few quarters through 2022. Why is the virus still around? So the big answer to that is the virus keeps mutating, meaning that the virus that was around in 2020 forms many different offspring, if you will. Some of them are a lot like the parent, just like in our own families. Some of them don't look too much like the parents. And those are the ones that it's harder for our body's immune system to recognize over time. And so the less the virus looks like the viruses that our bodies have seen before, either through a prior infection or from a vaccine, the more the viruses are able to escape the virus. The more the viruses are able to escape the vaccine. And again, because the viruses hijack our cells to make new ones, when our body makes new viruses, there's some sort of random parts to that. So they're not making the same virus every time. Sometimes the piece of a virus that gets assembled looks slightly different from the parent piece, if you will. And so our bodies learn to recognize viruses literally by the shape of the virus, what's the parts that are sticking out. That's how our antibodies work. It's like a key in a lock. The virus has a part of it that sticks out that our bodies can recognize. The antibodies snap out of it. Our white bloods snap onto it. And they say, okay, we've taken care of that virus, we've deactivated it. But if it looks new to our bodies, if our bodies say, wow, this virus looks different than the ones we've seen before, then the virus is better able to escape our defenses. And it turns out that the latest variants, B4 and B5, the ones that went around like wildfire this spring and this summer, they had exactly that advantage. They were more contagious because they were better at escaping our body's defenses. Also, they were so contagious that they could do something that the earlier strains didn't do very often, which is to infect people more than once. So with the older strains, if you had it once, generally you had all the antibodies and the immunity needed to protect yourself, but that hasn't been true of the last ones. So that's why they spread so crazily. And also the fact that they were different meant that they could actually infect vaccinated people. And this is what we talked about a lot again this summer and the spring, was breakthrough infections. That people who had gotten 1 dose of vaccine, 2 doses of vaccine, were getting COVID infections. Now, were they much less likely to end up in the hospital with those infections? Yes, absolutely. I'll show you some numbers about that in a moment. Were they much less likely to die from those infections? Yes, absolutely. So it's not that the breakthrough infections showed that the vaccines didn't work. It just showed that they didn't work perfectly. Okay, and that's an important message to get across. They still protect you from the most terrible outcomes of COVID, but you may have something that looks like a cold and a runny nose and a cough for a few days. Next slide, please. All right, so we're going to talk a little bit about vaccines for a couple of minutes because vaccines are the best tool we have, hands down, at protecting people from the vaccine. And if you're going to spread one message, that remains to be the main message to spread to your communities. Vaccines are the best tool we have. And there's been a lot of research done on that, and the numbers, I would say, are very reassuring and very protective. With 2 boosters, 2 initial vaccine doses, these are Pfizer and Moderna now, and then 2 boosters following up, that's 99% protection against death from COVID. Okay, you still might get an infection, something low intensity, but you're by and large going to stay out of the hospital, and you're almost 100% likely to not be killed by COVID. And that's what we all want in the end, is to stay alive and functional. 1 booster is very high still, 86% protection, nothing to sneeze at, if you pardon the pun. And so these are the important messages that we have to get across, because a lot of what's on social media or even in the news, as humans, we tend to focus on the failures, right? We don't like to fail, but the failure rates are very low with these COVID boosters. And so we need to emphasize that to our communities. Even without a booster, the initial vaccines still remain very effective against the new variants, 81% protection. That's pretty high. And these statistics are all coming from the CDC statistics that they collect from public health departments around the country every week to measure the efficacy. In the spring of 22, so just this past spring, unvaccinated people 50 and older, and that's the high-risk groups for ending up in the hospital or ending up in intensive care or ending up with a death of COVID-19, they were 42 times as likely to die from COVID-19 as people with 2 booster doses. Okay, again, going with, to show how protective they are against these serious infections. As you go around and talk to people in your communities, in your neighborhoods, in your clinics, the important thing at this point in the pandemic, in the fall of 2022, is the message that a second booster is important for people at risk. People with chronic diseases, with diabetes, with severe heart disease, who are taking medicines that knock down their immune system, like you might take if you have severe rheumatoid arthritis or severe asthma or different things. The first booster is good. The second booster gives you an important lift in your immune response, okay? So 1's good for boosters, but 2 is better, and there's very strong data to show that. People 50 and older with initial vaccine doses, the first 2 vaccines, and only 1 booster, they were 4 times as likely to die from COVID as people with 2 booster doses. These numbers are straightforward. I think they're reasonably easy to get across and to understand. Okay, 4 times as likely to die as people with 2 booster doses. So it doesn't have to be a complicated conversation with folks, just a reminder about what they're going to get from that first and hopefully second booster dose in terms of an effect to keep them alive and out of the hospital. Next slide, please. All right, now, I don't know how we got to this crazy place where wearing a mask was so politicized and the object of so much hate speech, if you will, but you know, it's gotten that far in some places at certain times. The straightforward, I think, recommendations to give people, again, in the communities, the people who are at risk that you're talking to in your daily work, these are the guidelines for wearing a mask. So certainly wear one when the rules require it. If you come and visit somebody at University Hospital who's sick for anything, they're going to make you put a mask on, and you should pay attention and follow those instructions. In certain schools or offices or spaces where there are vulnerable people, nursing homes, visiting, again, they're going to want you to put on a mask. And both the human, the thoughtful, and the scientifically right thing to do is to wear the mask when people are asking you to do that. Now, we spend the minority of our time in hospitals and nursing homes around high-risk people. We spend the majority of our time in our homes, in our offices, and in public spaces, visiting friends and so on. And so then it's up to you whether to wear it or not. And the way I frame it in a way that I think is the most accessible and the most human is to ask who around you is most vulnerable, right? If you go to a party, who's going to be there? If you're going to celebrate a birthday in a restaurant, who's going to be there? If you're having friends over at your own house, who's going to be there? And again, we don't necessarily know the health history of all the people that we socialize with. But if you do know something important about someone's health, the human and the thing to do is to try and protect them, because they usually will be trying to protect themselves. People with severe lung disease from, let's say, asthma or a smoking history, at this point should know that they're at high risk from COVID or ending up in the hospital or on a ventilator. They're trying to protect themselves. And our job, our role as people who socialize with them, who share a house with them, who share an event with them, is to help them protect themselves, right? Even if we don't feel ourselves to be at risk, the right thing to do is to help high-risk people protect themselves, because that's what communities do. And that's, to me, that's the most humane way to think about it. Now, there are times when rates are low, and our health department would say, we can relax on masking because in general, very few people in a room. We can expect that very few people in a restaurant or in a party. The rates are so low that we don't think too many people will be infected. And so you can maybe relax on using a mask. But again, even when the rates relax, it's still about who's right next to you, who's elbow to elbow with you at the time that you're inhaling and exhaling and talking and celebrating and all that. So it's more about who's in your space at that particular moment. And then there are certain places where we know it collects a lot of people from a lot of walks of life and a lot of infection risks that you don't know, like public transit, for example. Again, people on the bus aren't going to tell you that they have severe rheumatoid arthritis and they're taking high-dose steroids to protect themselves. But probably on any given bus or the buses that you ride in a week, there will be people like that on the bus. And so if we're thinking about how to protect each other in times when we don't know everything about everyone around us, it makes sense to wear a mask to protect them as well as ourselves. I'll say, as someone, I was just in Italy for some family travel. Started out as a funeral and then got happier after that. I flew back on a 10-hour Delta flight yesterday. And there were very few masks on the plane, even though we were 10 hours in the same space with 300 people, 300 strangers, essentially. You know, my wife and I wore masks, and there were some people wearing masks the whole time, but I would say it was maybe 5 to 10%. So that's just where we are. And again, we have to know what we feel comfortable with about, you know, risks and both assuming risks and providing risks to other people. That's a conversation that's going to keep happening as the pandemic evolves. Next slide, please. Oh, and I should ask, there was also, and that's why I'm going to be sitting in my office alone for a few days, there was a heroic amount of coughing and sneezing on the flight. And so it could be that there were a lot of allergies around, or it could be there was a lot of COVID around. I'll tell you in a couple of days, in a day or two, when I start doing my self-test. But I'm going to be lonely for a couple of days until I feel confident I'm not spreading it. Okay, so again, the rule of thumb: if you can feel the breeze on your face, you're probably okay about spreading, unless you're very packed together, like the Rose Garden party in the White House, where that was outdoors, but it looked like there were hundreds of people from both government and the press corps, all, you know, very packed together, so that people were still 6 inches away from each other as they were talking. In that case, there's still some risk, even though you're outside in the breeze. Next slide. There are some great resource guides about talking about vaccines available, and there are probably dozens of these right now available through NIH, through CDC, through local health departments, through local public service agencies. Here's some community resources that we collected: question and answers, how do you respond to questions on different topics. They're available in both English and Spanish, very helpfully for our community. And so I would encourage you, if you're looking for ideas about how to talk about certain topics, to make use of those resources and see if you can just pull a few ideas down that might help you in your daily work. All right, and I want to close with a couple slides just on vaccine hesitancy and some other issues. This hesitancy umbrella has become the way that we talk about vaccines. You know, and it's okay because it communicates the idea that someone may not be opposed forever. It's just they're hesitant to take the plunge and get a vaccine. The problem with hesitancy, though, it's a very broad umbrella. Someone might be undecided, or we call them vaccine hesitant if they say, there is no way on earth I'm taking a vaccine, right? They're all under that umbrella. And so you can approach someone who's undecided and maybe on the verge of making a decision to have one. It's very different, the conversation you're going to have with them, from someone who's like, no way, you know, no way on earth I'm getting a vaccine, because one person needs a nudge and the other person needs a big time, you know, shift in the way they think about vaccines and their responsibility and all that. And so I saw very recently a nice way to think about it that even helps you remember it. Consider the 5 C's, which are confidence, trust or mistrust in the vaccine system. And again, as you all know very well, a lot of people have mistrust because of social exclusion and, you know, difficult conversations with medical providers in the past, and feeling like they're not heard and their communities are marginalized and all that. All of which are very valid concerns. So one is talking about confidence. The other is practical things. Do you have time to go to a healthcare site to get one? The fact that the vaccines are free, but the administration costs are not, right? And so do they have the money to go somewhere and pay someone to administer the shot? Another one, the third C, is complacency. They don't see themselves at risk from COVID-19. They're 19 years old, their health is good. They probably by now know 80% of their friends or 90% of their friends have had COVID, got over it really quick. They don't expect that their reaction is going to be any different. And so the vaccine just seems like an unneeded hassle for them, right? That's going to, again, be a different conversation, maybe centering about, well, you're not at risk, but do you ever visit grandma and grandpa, right? Do you have any friends? Maybe you have some friends who don't tell you, but they're taking drugs that suppress their immune system for an illness they may want to talk about publicly. So again, that's a different kind of conversation, a different direction. Some people are still weighing the risks and benefits. What are my odds of getting COVID? What are my odds of having a bad reaction to the vaccine? Which one seems like it's more probable to me? Which one should I weigh the most? That person might benefit from some easy to understand numbers about the risk from vaccines and the risk from COVID. And so you might give them some different resources. And then there's a collective responsibility. If someone is very motivated by that, I help protecting others, you might go that way, versus if they might be more self-motivated. Well, if everyone else is vaccinated, why do I need to be? Because everyone around me is protected. I live in that bubble, right? I can be a free rider, if you will. You probably wouldn't use those words with them, but that's another way of thinking. So if you put these 5 C's on an index card for yourself to remind you which things to ask about and how they all point in different directions for the kind of conversation you might have, I think that's a useful way to approach those conversations. Next slide. I just want to remind you that there's an expanding menu of antiviral treatments these days. These are not vaccines. These are drugs that interfere with the virus reproducing itself. And these would be available through a healthcare provider for someone who's at high risk. They have different ways that they're administered. Some are taken orally as tablets. Some have to be given by an IV infusion at a healthcare site. So these are things that, again, these are going to be mostly people at high risk. If it is someone who's taken drugs that suppress their immune system, been vaccinated, somehow still, or not vaccinated, but somehow still test positive for the virus, these things need to happen as quickly as possible. And so from a community health worker point of view, it's getting out the messages that for vulnerable people, don't be fatalistic if you do feel like you're getting COVID in a high-risk situation, but you have to move quickly to connect with these therapies. And that's the main important message that I would try to transmit. And then finally, last slide, and then we can have some conversation, is this idea of long COVID. And every week now, there are probably hundreds of new studies, investigations into what is long COVID, how does it work, how do we avoid it if possible at the front end, how do we treat it at the back end. Our own Health Science Center has a very big long COVID effort underway. And as time goes on, there will be more trials for people suffering from long COVID. There will be more follow-up studies so that we can fully understand what that illness looks like, and how long it's going to last, and how we counsel people suffering from it, so that we can provide them with good advice, treatments, hope, in a space that's been not very well described until now. But we're going to learn a tremendous amount in the coming months and years about what long COVID is, and hopefully how to help people manage it. So again, to help people not be completely negative about, well, there's nothing to be done, it's new, I don't know, but to let them know that connection with care is possible and they should take advantage of it. And that takes me to the end of the slides. I'm happy to hear your reactions, questions, thoughts, relevant experiences that you've had that you'd like to share.